is there anything we as patients can do to prevent Richter syndrome, or is it just something that would happen?
So the answer is there's probably nothing that can be done to prevent it happening. About half of Richters occur in persons with previously untreated CLL, and the other half in people who've been previously treated. There's a school of thought that previously that treatment with ibrutinib might increase the risk of this, but that's been now thought not to be the case. Previous argument was put when fludarabine, a previous chemotherapy, was introduced. What's probably actually happening is each time you introduce a more effective therapy, the outcomes are better, people survive longer, and then get the Richter syndrome because they've lived longer. So there probably isn't any particular treatment that increases the risk of it as such. The only thing is to be alert to a lymph gland that's getting bigger fairly rapidly and to seek advice.
Okay. Right. Questions from the room?
Can I just ask a question about MRD testing?
Yeah.
Just in terms of what current thinking is in terms of number of cells that are looked at and all that kind of thing?
So MRD, that stands for minimal residual disease. And MRD is one of the ways that the CLL can be monitored, particularly after people have had a fixed duration of therapy. So some people have a therapy in the past with a chemotherapy called FCR, and more recently with ibrutinib and venetoclax. And these treatments are so effective that at the end of treatment we would expect all the lymph glands to have shrunk down, the blood count to go back to normal. But it is known that a portion of people will have disease that remains detectable at a certain level. And there's methodologies whereby you can count those abnormal cells. So peering down the microscope, you can spot about 1 in 100 abnormal cells. With the method called flow cytometry, you can go down to about 1 into 100,000. And some other methods go down to about 1 in a million. There's a very active debate amongst the scientific community about how you do this and what level is more relevant than any other level. In the UK, because the FLAIR trial showed that giving ibrutinib and venetoclax and then using MRD to decide when to stop the therapy was an effective approach, the UK very strongly buys into the approach of MRD monitoring. That isn't the case internationally, so not all countries and CLL groups accept that you need to do MRD monitoring. Some take the view that, particularly a continuous therapy like zanubrutinib, it works. A lot of people do have residual MRD, but as long as the treatment is working, the person is well, then not to worry too much about it. And MRD, even in the UK, we're not at the point where MRD is routinely used to guide treatment decisions, though that may change if ibrutinib and venetoclax is approved by the NHS as it was used in FLAIR, which is not a given, I'm afraid.
Okay, we're going to take a question from our Zoom attendees, and then I'll come to yourself. Yeah, thank you.
Thank you.
Which camera do I look at for Zoom?
Just carry on.
Okay.
Is there research looking for the cause of CLL to prevent it occurring in older age?
So yes. So there's been a lot of research over the years as to why does one person get CLL and the next person doesn't. And there's been a lot of work trying to track back where the CLL comes from. So CLL is a cancer of immune cells, and a type of immune cell called a B cell. And there's lots and lots of different types of B cells. And there's a school of thought that it originates from one particular type of B cell. However, that knowledge hasn't yet translated into clinically useful information for treatment. What was the rest of the question? I've already forgotten.
Is there research looking for the cause of CLL to prevent it occurring in older age?
So the research, there's an understanding about how CLL arises. There's a lot of epidemiology type research. So the University of York has this regional data collection over about 4 or 5 million people across Yorkshire. And one of the drivers for that research is to find out whether, I don't know, living under a power pylon or having certain occupations or eating blue Smarties or some sort of correlation that might cause this illness. So persons who are diagnosed, there's a questionnaire that goes out to persons of consent, and then all these questions are asked. So as yet, nothing's really come out of that. So there isn't a clear trigger for CLL. The thought is it represents some sort of change in the immune system. As the immune system gets older, as people get older, the immune system does change such that diseases like CLL may be more likely to emerge. So that there isn't as yet a way to actually prevent it occurring.
Just a question with reference to the pathological symptoms of CLL, such as night sweats and fatigue. Yeah. Do the new treatments in terms of medication, do they have an effect on these symptoms? Do they reduce them? Do they eliminate them? Or whatever? Okay.
So it depends on the context of the symptoms occurring. So for somebody that we meet who has stage C disease that's moved down the track a bit, who's got swollen lymph glands, they're anemic, they've got low platelets, they've lost 2 stone in weight, treating the CLL will make those symptoms better. For the person with a sort of more early stage CLL that's moving forward, the white count's going up, and that person's having problems with low energy, had to reduce their hours at work, treating the CLL may improve those symptoms. So generally, treating CLL, I can be very, very confident I can make all the blood tests look better. So I can make the white count look normal, I can make the lumps shrink down, do all that. We can make all the things on the tests and scans better. The fatigue is really difficult. Yeah. So some people, the fatigue and tiredness does improve, but not always. And one reason for that is sometimes we just give you another reason to be fatigued with the treatment we've offered you. But another reason is the fatigue, the cause of the fatigue. It's often more than just an all or nothing with the leukemia being active or not. Yeah. And I don't have a good answer to. So some people struggle with debilitating fatigue, often after treatment or in disease that's stable and not meeting other criteria for treatment.
I wonder if I could just ask just a quick supplementary to that.
Of course you can, yeah.
In terms of the fatigue, I read online somewhere that in America, that patients can actually get treatment for the fatigue. But I've never seen anything in this country. Is that because GPs are afraid of prescribing stimulants or something?
I've not come across anything that's compelling treatment for fatigue. Right. If you can identify a cause of the fatigue, so you can identify whatever that may be, CLL or diabetes, or sometimes fatigue can be associated with low mood. If you can find a cause and treat that, then that's fine. Yeah. But there isn't a fatigue treatment. Right. And I would bet if you looked at the details of that place in America, there'd be a charge with that, tens or hundreds of thousands of dollars. So there isn't a drug intervention that will purely improve fatigue.
Yeah, thank you.
Can I just add that we've started a group within CLL Support called our STAR group. It's Studies, Trials and Research Group. And the group that we talked about, the NCRI, that has been disbanded, there are a group of clinicians involved in that. And our input to that, one of the key points, which is borne out by the survey, is fatigue. And what we've said is, if the study of why fatigue happens is too difficult to figure out, which seems to be a common theme, why not look at ways of coping with fatigue from a clinical perspective, not from a good ideas perspective. So
I think that's a very good point. And then the other thing I'd say about fatigue is that everybody is different, obviously. And everybody's experience of fatigue is slightly different, and the drivers into it individual will be different in each person. And that's one of the difficulties. And I think what you suggest about trying to treat what you can treat, but then thinking about how you live your life around how you feel is very sensible.
What are your thoughts about whether it is hereditary? I mean, my father had CLL, I have, and my brother has. Yeah. So the chances of that. Yeah.
So I suspect you've done your reading, but it's known that about 5 to 10% of persons with CLL will have a familial element to it. And in those families, predominantly it's male, but not always. And in some of the families, it can show an effect called anticipation, where each generation it occurs at a slightly earlier age. So this observation was a driver about 20 years ago for the Royal Marsden to look at the genetics of CLL, but also the genetics of those persons in whom the CLL is familial. And it was found that there are up to about, how many are there? I think it's about 40 genetic markers that collectively can increase the risk of having CLL. And the more markers you have, the more likely you are to pass them on and therefore have a familial element. That said, and this is true for all cancers, so this is also true for bowel cancer, breast cancer, prostate cancer, and so on. All cancers, there is a slight element of genetic susceptibility in some people. That said, though, it's not like some inherited disease that I look after. So I look after a condition called haemophilia, where it's the case that if a woman is a carrier, there's a 50-50 chance that someone will be affected. It's not the case that if you've got a susceptibility to CLL overall, that it's a given that somebody in your family will or won't get it. So overall, it increases the risk to a variable degree, but the risk overall is still low. But there are some families, about 5 to 10%, in whom it can run through the families. Doesn't necessarily follow that the leukemia is more or less easy to treat in those circumstances, though.
Debbie?
Okay, another question from one of our Zoom attendees.
Mm-hmm.
I'm 57. I have had autoimmune hemolytic anemia once, 5 years ago. Am I more likely to get it again or not?
So with the caveat that I can't give individual medical advice, the answer is maybe. So autoimmune hemolytic anemia, it's a complication that's triggered by the immune system being out of balance. We see people with autoimmune hemolytic anemia who don't have any underlying blood cancers, and very often it can be just triggered by a common viral infection. And that also applies to people with CLL. So it may well be there's been one episode of hemolysis 5 years previously that was triggered by some unknown virus. That's worked its way through the person's system, and it may not happen again. But equally, if there is CLL there, it could happen again.
Just let me.
Can you tell me more about the drugs available with the static trial? Because I'm on flare.
Yep.
And I've been 4 years in remission. I'm lucky to be 4 years in remission,
Fantastic.
having had ibrutinib and venetoclax very successfully. And I'm just interested if consideration is given to flare patients for the static trial.
So the static trial was conceived by Professor Hillman and Dr. Munir essentially as a successor to flare, with the aim that enabling people who'd had ibrutinib in the flare trial to then continue with an approach based around ibrutinib. With the ibrutinib venetoclax, there is a slight caveat that within flare, if you have a really fantastic response and you have no detectable disease by the sensitive monitoring test, the MRD, that you would then you may be allocated to stop the I+V therapy and go on monitoring. In the flare trial, there's a maximum of 6 years therapy. So if someone was on I+V at 6 years and they hadn't met what's called the stopping rule, so you're still on the treatment, then you would then be potentially eligible to go into static and then be randomised to either start and stop the ibrutinib or continue the ibrutinib. So it's something you should talk to your treating clinician about.
Can spontaneous remission occur in CLL?
No.
Thank you.
David, you earlier on were commenting on your really helpful slide about 7 things to do for patients. One of them was if treatment is needed.
Mm-hmm.
And then I'm going back to when you were talking about the carer being in the treatment room and looking daggers at the patient and at you.
Yeah.
So And when I was speaking earlier, I was commenting that maybe we ought to make sure we tell our medical team about infections and about bruising and things like that.
Yeah.
So what are the symptoms that it's most helpful for people to mention when they meet with their medical team?
So the line I take with this is rather than going through a have you had this, have you had that, have you had the other, the correct way to do it is that you've probably already formed a sort of a relationship or connection between the treating clinician and the person you're seeing. So so the line I take is I explore what's important to that person in their life. What do they do? Do they work? Do they not work? What activities they like to do? And then explore how the CLL may be affecting how they live their life. So bruising, to be honest, is an uncommon symptom, and if it happens, it's usually a marker of other problems that would be apparent. And the fatigue, asking, do you feel tired, is not that useful, because most people ask that question would say yes. I would say yes if someone asked me. It's more, how's the job going? Oh, well, I've dropped my hours, I'm struggling, I start later in the morning. It's exploring how the disease or how the person's health in general is impacting on the life. So to go back to your point about how do you facilitate a discussion, the first thing I would say is I would always advise somebody to bring someone that they trust for support with them. Some people actively choose not to, which is absolutely fine. But I would encourage people to think about attending a clinical appointment with someone like me with somebody. And then try and have a discussion really about your life and what's important for you and how is your health affecting your life and what you want to do. That's the line I would go down.
Your slide said that you say mutated as good and unmutated as bad. Is that right?
Bizarre, that, isn't it? Yes.
I just wondered if, with all these new treatments, will that be redefined? Is it going to become more negligible, the difference between mutated and unmutated, if the drugs are as effective for both kinds?
That's right. So it's a slightly arcane discussion now. Again, about 20 years ago, it was worked out that CLL was not all one disease, and that probably CLL arises from a different normal immune cell in different people. And the mutated thing talks about a gene called immunoglobulin gene. So B cells and CLL cells make antibodies, and you can detect what sort of antibody-making cell the CLL cell is. And then it came out that if you're one type, your disease is more likely to be stable. If you're another type, you're more likely to have progressive disease, and that's given the name mutational mutated. So yes, there is a school of thought that now says the treatments are so effective that this is all irrelevant, and when you look at the clinical trials, the outcomes still do vary a bit. So if you have, for instance, an unmutated CLL with other abnormalities, then you probably do a bit less well with whatever treatment you're offered. But there's no evidence to say that you should, if you have this pattern of abnormalities, you should have that treatment and then that one. So there's no evidence yet that you use this information to alter frontline therapy. It's a question that's been repeatedly asked, well, if we do this test, if we identify unmutated CLL with this abnormality, should we give something more intensive? And the upshot of all that is that it doesn't seem to make any difference. So it gives you a bit of extra information as to how likely the therapy is to work. But again, ultimately, you know whether therapy works or not because you can tell whether you can monitor somebody and see what the response is. And you never quite know. So not everybody with disease that has more poor prognostic markers, some of those people will respond really, really well to the treatment you give. So you just can't be didactic about it. You just have to have a go with a treatment that you think is right for that person. And
I was just wondering about COVID and CLL, having had COVID 6 times. I'm currently on treatment and I've had it 3 times whilst on treatment. But have you seen any other issues related to COVID and CLL, such as lung nodules?
So we've got an infection expert at the back of the room
Really?
who will know more about this than I do.
Right.
Persons with CLL are as likely to develop complications from COVID as people that don't have CLL. So I'm slightly off my territory talking about COVID and long COVID, but some people do have significant long-term problems with COVID. Often those people have markers of lung damage or other organ damage from being very severely unwell. I don't think there's anything about CLL that would increase the risk of, say, lung nodules. That's a sort of marker of the severity of the COVID in the first place.
And would that have an impact on where you are in your CLL journey? So if you're relapsing and get COVID and you're quite unwell, you know, would that then have an impact how your body attacks, you know, the cells that are going on when you've got COVID?
It wouldn't have an effect on the course of the CLL per se. If you became very ill from the COVID and had lots of health problems, that might then impact on your ability to have certain therapies afterwards. But it wouldn't impact on the course of the CLL subsequently.
We're stealing a little bit of time from lunch, but as we're not going to feed the 5,000, I think that's okay. So maybe the final question.
Hi. Could you tell me if there's a limitation on the amount of treatment you can give a person over a period of time? So if the younger you are, you start treatment early, do you run out of options as you get older?
Well, potentially, yes. That used to be a problem sort of 10 years ago with the chemotherapies that we used that tended to have a shorter duration of mission. So some of the chemotherapies we used that were effective, but people would typically relapse 3 to 5 years after having the therapy. And some of the chemotherapies can cause problems with low blood counts or kidney problems. You could get into you can get into problems when you get through second and third lines of treatment. With the current therapies that are highly effective, so BTK inhibitors, so we've got people who've been on them for 10 years or more, there isn't really any data beyond 10 years as to what's likely to happen. But the survival outcomes that are known are excellent, and so that isn't showing us yet. It isn't showing that people are running out of options. And there's a new drug coming through about every 18 months, every 2 years. And as time goes by, so that there is a slight issue with how the NHS approves new expensive treatments, but over periods of time, the treatments lose the patent and become what's called generic. And then are more readily accessible. So that's not for the vast majority of people, that's not a problem that we run into.
David, thank you very much for a fascinating talk.